Well, good afternoon, and welcome to our final session of ASBH's 2024 Annual Conference. My name is Patrick Smith, President-elect of ASBH, and I hope that you have enjoyed this year's slate of programming. And even if yes, give it up. That's right. See, we still have some life in the place. This is good. I certainly hope you've been able to think about these questions, and maybe if we don't have final answers, maybe we can have better formulated questions regarding our conference theme, what does it mean to be human? As a reminder, conference evaluations are available now through December 31st, and we strongly encourage everyone to share your feedback and help shape the future of ASBH programming with regard to our annual conference, whether or not you intend to claim continuing education credit for these sessions here. Before you all rush out to complete your evaluations, which I know that you're so eager to do at conferences like this, we are pleased to have one final plenary session, Good Days, Bad Days, and Reflections on Reducing Workplace Violence in Healthcare Settings with Dr. Rozel. Dr. Rozel began his career in emergency mental health as a suicide hotline volunteer more than 30 years ago, and he has been the medical director of Resolve Crisis Services of UPMC Western Psychiatric Hospital since 2010. He also serves as a professor of psychiatry and adjunct professor of law at the University of Pittsburgh, and previously served as the president of the American Association for Emergency Psychiatry. Dividing his time between emergency psychiatry and violence work, he has worked locally and nationally to improve crisis services for patients and communities, and has been involved in a number of efforts to improve the interface between the legal and mental health systems by currently serving the Commonwealth of Pennsylvania as a member of the Citizen Law Enforcement Advisory and Review Commission, the Mental Health and Justice Advisory Committee for the Pennsylvania Commission on Crime and Delinquency, and the Threat Assessment Steering Committee for the Office of Homeland Security. Dr. Rozel's contributions have been recognized by organizations including the National Alliance on Mental Illness, CIT International, the American Psychiatric Association, and the American College of Emergency Physicians. Please join me this afternoon in welcoming Dr. Rozel.
Thank you, Dr. Smith. All right. Thank you, Dr. Smith, for that wonderful introduction. Thank all of you for being here at the very end. Oh my gosh, you are like the super ethics people, right? First of all, humbled and honored to be here with you. So thank you to the association for bringing me into your meeting for this. And again, thanks to all of you for coming out to join this last swing, right? So when Dr. Skahosky reached out to me a while back and said, would you be interested in speaking, it occurred to me at the time that I was having a really good day. And it got me thinking about a conversation I had when I was an intern 25 years ago, when I was working in our psychiatric ER sort of well into the evening, and we had this wonderful AOD. She was a nurse. She was an ER nurse turned AOD for the hospital by the name of Barbara Bana, and she came down just sort of checking on everything, and she's like, hey, Jack, how you doing? And I don't know, I was whining about something. I don't know what it was. It was certainly nothing that significant. And she said, well, are you having a good day or a bad day? I'm having a bad day. She said, well, was somebody hurt? I said, huh? So was a patient hurt? Was a staff member hurt? And I said, no, I'm whining about something, right? You know, I'm an intern, that's what we do, right? And she said, well, you know, the only bad days are if someone gets hurt. Everything else is a good day. And 25 years later, I find myself thinking about that conversation a lot, and how much it shaped me in how I've prioritized what I've done in clinical settings, both as a physician and hopefully as a leader. And one of the things it's sort of evolved to in my mind is like, you know, the good days are when nobody gets hurt. And for me, the great days are when I get to do something to keep folks a little bit safer. And I'm going to share with you a little bit of that today, all right? All right. I've been pharma-free for a long time, I'm happy to say, but I do a lot of sort of work in this space. And I also feel like I kind of have to confess, like I did my bachelor's degree in medical ethics. That was, okay, thank you. But also, don't let the youthful good looks fool you. That was longer ago than you might think, right? And so, you know, I'm an operator. I'm kind of a knuckle dragger. You know, I do the clinical stuff. I'm not necessarily always thinking about these higher level ethics things, although I have the absolute joy and privilege of working with Dr. Parker at the Center for Bioethics and Health Law at Pitt, for which I'm deeply, deeply grateful for all of those opportunities. But I'm not like a super ethicist, right? So I hope I get some of this stuff right. I am also a past president of the American Association for Emergency Psychiatry and just a little bit of a shill for the association. And we have dropped a whole set of resources over the past decade or so about how to do better at managing agitation and aggression in the workplace. And by the way, if we did it right, there's going to be somewhere posted in the forum, there's going to be a PDF of all of these slides and a list of all of these articles, and they're almost all open access, so you'll be able to get them. But yeah, like if you want to, this would be this good slide to take a picture of, but they'll be hopefully you'll get all the slides later on, right? But a lot of really good resources here for you, right? And then one final disclosure, and we'll get into the meat of it. Right now, my little girl is back home with my wife in Pittsburgh. She just turned 12 the other week. And the running joke between her and I is, you know, whenever she knows I'm off to give a talk, she says, "Daddy, what are you talking about this time?" And my answer is always rainbows and puppy dogs. Because, folks, if I'm the dude invited to speak to you, there's legit like one slide on rainbows and puppy dogs. And the rest of it can be sensitive. The rest of it can hit home in a very real way. If you need to get up and take a walk, honor yourself, respect yourself, and I hope you're able to come back to the slides later on and get something useful from it. But again, just forewarned that we're going to go to some different spaces here today, right? But if nothing else, these are the key points I want you to walk away with, right? Agitation is a medical emergency, just like an MI, just like a trauma code, right? We need skilled multidisciplinary teams to understand, to respond, to manage them safely. Working in healthcare is dangerous. Working in healthcare shouldn't be dangerous, and we need to make working in healthcare less dangerous. Caring for staff is definitely expensive. Not caring for our staff, not caring for our teams is far more expensive in ways that will never hit the budget, right? Because it's hard to care, it's hard to heal, it's hard to teach, it's hard to learn, it's hard to lead that effective healthcare organization if you're not safe. And being safe, it isn't just this sort of nebulous feeling, but it's cognitively knowing what are we doing to make ourselves safe and make our team safe and make our workplace safe. And do we know and believe that our teams and that our organization are doing the same for us? It doesn't mean pretending that we are, you know, horticulturists in a greenhouse. It doesn't mean walking around in like a giant steel hamster ball trying to defend ourselves, but it means being thoughtful and reasonable about managing the risks that we face, right? And so we'll talk a little bit about that today, right? So first off, I want you to think about agitation as a medical emergency. And as a psychiatrist, that's sort of like, that's our medical emergency. A lot of times in institutions, someone starts revving up, they call security, and it becomes a tackle and shackle after that, right? I would argue it needs to be something very different because the etiology of this behavior is really complex. And if we don't get it right, someone can get seriously hurt. Staff, patient, both. We need to understand the causes. We need to have thoughtful, intelligent interventions. We can't just snow them with ketamine and wait for the next shift to deal with the problem, right? We have to be thoughtful in how we approach this, because if we get it wrong, someone could really get hurt, right? Now, I want to be clear, right? You know, the nearest hospital to my main hospital is a place called UPMC Presby. It's sort of right across the street. I'm at Western Psych. But they have a Starbucks in their lobby that we don't have in ours, right? You can see the differential here, right? So if I'm walking over to get my, morning latte, and I grab my chest and I drop a Vestemi in that front lobby entryway, you know what? That safety officer might kick things off. He might do some compression, slap on the AED. If he's feeling brave, they may even, do a couple rescue breaths. But when the code team arrives It's a team response. And they may still be playing a critical role, doing compressions, grabbing the code card or the gurney or whatever else they need to do. But we're looking for someone with good clinical expertise to manage this, because if they don't, something really bad could come of that. And part of why we care about this is it's the leading cause of staff injury, and we'll talk about some of those numbers, right? And when we get it wrong, it leads to and sometimes feeds into this vicious cycle of staff turnover, of staff confidence, of staff fear, right? It's hard enough to learn how to manage this type of behavior in general, but it's so much easier to learn it from, a nurse like Barb Banna, who'd been doing this for a lifetime, than another nurse who's also awesome, but maybe has only been doing this for a year. And I don't know about your health system, but I've seen a much faster turnover, a much shorter sort of life cycle of people working in healthcare these days. All right. And by the way, I want to be very transparent. I put an asterisk on agitation. We need a better word for agitation. We need a better term for this. We need something better than agitation and aggression. There have been a couple studies I've seen over the past few years where they do, their fancy computer analyses of electronic health records and say, where are we seeing the terms, a number of terms, but agitation and aggression, and whose charts are they showing up in? And if you thought that they were disproportionately showing up in the charts of white patients, you are absolutely wrong. It breaks down by color of skin, and we've got to find out what that means and how to do better by it, right? All right. Okay, so if you're taking your occupational safety and health exam, right, there are four broad clusters of violence in healthcare. Number one, criminal outsider, right? So this would be someone knocking over the convenience store. This might be someone committing an armed robbery at the pharmacy to get a hold of controlled substances. It might be someone mugging you for your wallet as you go out to your car at the end of a shift, right? We actually don't see a ton of this in healthcare, but we do see at least a little bit of it. Customer, in our case, patients and visitors versus employee. This, I'll tell you, in psychiatry, we see a lot of this. In emergency medicine, they see a lot of this, right? Employee versus employee. We don't always think of this, but it's a real thing. We call it insider threat, right? UPMC has roughly 100,000 employees. Not everyone gets along awesome. And I'm told historically, I've never seen the source documents, but I've been told that the first shooting on a higher education campus in the United States was a duel that happened after a departmental meeting. Yeah, maybe, right? And personal relation, like someone from our lives, especially intimate partner violence, who's endangering us outside of work, and we step into the workplace, and that danger follows us into the workplace, right? These are the classic categories of violence. In healthcare, we also worry about some other stuff, right? So a buddy of mine, Steve Cremando, talks about, sort of category 5, which are facility-based attacks, which might be ideological or might be otherwise, right? Especially reproductive healthcare as a good example, right? And then the wonderful Dr. Emily Tran-Su, who I had the pleasure of mentoring with Dr. Parker here some years back, came up with sort of extended this in a really nice way, right? How do we protect our patients, right? The criminal outsiders coming after our patients. Maybe it was a shooting in the community that didn't get quite completed the way someone wanted it. So now they're coming to finish it off in our workplace, in our place of healing, right? Patient on patient, we see that. Employee on patient. Thankfully, we don't see a ton of that. But the mere aspersion that something like that happened can be devastating to systems. And by the way, especially for those of you in risk management, think back about the last few times you saw a healthcare system dropping a check for hundreds of millions of dollars. It wasn't because they operated on the wrong eye, the wrong knee, or gave a transfusion of the wrong type of blood. It was because someone was sexually assaulting patients over and over and over again. And people were looking the other way, probably because of the power of that white coat privilege, right? And oh yeah, in psychiatry, we also worry a lot about when our patients go after someone else, like I want to go kill the governor, the mayor, whoever else, right? So we got to worry about all these things. Now, by the way that our staff are most likely to get injured is a patient or sometimes a visitor or family member attacking them, right? But the most common way that a medical professional will be killed in the healthcare setting is a paramour or former paramour who's followed them into the workplace, right? Just let that sit with you for a little bit. And think about some of the really great workplace relationships you've seen, and some that maybe weren't so great, right? All right. So, healthcare is the #1 cause of disabling workplace injuries in the United States. Every hour of every day, if someone is getting injured to the point that they're going to be disabled and not be able to come back to work for a day, a month, or the rest of their career, the most likely place that they're working is a hospital. That alone could be our headline. That alone could be what we spend the rest of the time thinking about and talking about in the context of workplace violence. And it is just the beginning. The impact of so much else that happens in healthcare, the non-disabling injuries, the verbal abuse, the threats, the fear, right? The sense that I'm not safe in my own workplace, I'm not safe working with my own patients, the fear of taking on the tough cases or the cases with the tough families, right? And how often are you, as the medical ethicist, right there in the middle of that, in the family room outside of the ICU or down in the ER, helping the treatment teams and the families negotiate through those very treacherous waters, right? And we know these kinds of conflicts cause lots of problems. We know that they cause stress for the families and for the patients. We get worse clinical outcomes when we have these kinds of conflicts. And so navigating them successfully is critical, right? I will leave this quote up there for you to absorb for a moment. It's from Carmen Parker, who's a psychiatrist out at Yale, who's done some really fantastic stuff in the space of workplace violence. And I think she and her colleagues are absolutely right. We've got to remember that as scary as some of these incidents of workplace violence can be, and they can be really scary, and they can be really bad, we're a hospital first, right? We're a place of healing first. Everything else we've got to figure out downstream, but we've got to remember to prioritize what are we doing for our patients, what are we doing with our patients, and how do we center that mission, right? Now, how many of you have maybe a committee or a working group, or even just sort of, you get the email, like we have to talk about the problem patient or the difficult patient, right? Cool. Let's compartmentalize and project and other them, right? And I was actually asked to write an article once, like, hey, we need to do a review article on difficult patients. I'm like, yeah, but that's just like one part of the problem, right? Ask me about the difficult doctors, right? Ask me about the difficult staff. Ask me about the difficult systems that sort of fosters these problems, right? And what's our broader responsibility, not just as who we are as ourselves, but how we interact with our system to try and do better and do right for all these folks, right? Well, it's nice to be able to throw money at it, right? One of my mentors in this space says, affordable, accessible, secure, choose two. And if you're in healthcare and you didn't choose accessible, what are you even doing, right? How are your patients going to get to you, right? That arch metal detector at the entrance of the hospital or the ER, well, it may be helpful. And also, it may cost a lot of money, right? And we start to measure some of those. I saw some hospital administrators nodding on that one, right? We're measuring these security costs against another nursing position, another chaplain position, spending more money on the medications whose costs are going up, offsetting the cost of the care of the patients and families that can't afford it, right? They're very real costs. And sometimes what we're buying with it isn't quite what we think we're getting for it, right? There's a wonderful researcher, Bruce Schneier, who talks about this idea of security theater, right? How many folks are flying home today or tomorrow, right? How many folks are thinking, I'm going to wear non-lace-up shoes because they're going to make me take off my shoes tomorrow, right? Right? The rest of us are lucky enough maybe to have pre-check, right? To deal with a threat that hasn't arisen since, right? That's kind of what we talk about, like when we're doing security to make it look like we're doing something to make it secure when it doesn't actually make it secure. That uniformed law enforcement presence out in front of the hospital, for someone who's thinking about causing mayhem and sort of pulls up and sees Officer Friendly up there and says, maybe not this location, maybe I'll go on somewhere else. Sure, that might help. Does it deter that former employee who's pissed off at their boss? That person who's pissed off at a former paramour, or who's loved one in their perverted mind is suffering on inpatient. And, the murder-suicide that's just an extension often of domestic violence that's been there all along, right? Might not deter them much at all, right? But that young punk who's thinking about maybe popping up in the waiting room, yeah, they might be a little bit more chill, or they might lightning rod and start with him, right? What about the migrant laborer with the crushing substernal chest pain, right? What about the parents of that little infant who has a fever of 103 that might have even been born in that very hospital, but the parents were born a little bit further away and maybe they don't have all their paperwork, and they pull up and they think, ooh, maybe not today, because we're worried about the ramifications of an officer being present, right? And what does it mean if this person's leading the intervention for someone who's agitated, right? And when they've been raised in law enforcement, where it's how do we use firearm, how do we use lethal force, right? Not saying they do it, it happens. It is vanishingly rare, but it happens. And a gun is a terrible way to de-escalate someone when we have so many better tools available, right? And yet, not just in hospital settings, even in some of our outpatient settings, we get this, our staff get frightened of something, and they have cause to be frightened of some of these things, but they have really high expectations of the security that we can provide. I'm feeling like HIPAA issues and boundary issues, and again, I don't have a billing code for this. I don't know how to offset this out of the budget. And I've had the conversation more than once with folks on our outpatient teams like, I'm scared, I need something more. And we've got to figure out how to help them feel less scared and how to help them be safe, but realizing that's not a practical tool. Now, I also want to be clear, there have also been circumstances where I've put armed close protection on some of our staff because we've been concerned about their safety, right? Because that was the right intervention at the right time. But one side, the fantasy that one size fits all quickly becomes one size fits none, and it's a rough way to waste very, very finite resources, right? And security absolutely plays an important role in the healthcare setting. They're a vital part of what we do. They protect the mission, but you got to do it right. I have concerns, right? It takes time and it takes money and it takes ongoing training. And by the way, when you only have a couple safety officers at a hospital, they're kind of isolated from the rest of law enforcement and continuing education and training. And so we've got to make sure that they have the resources for all of that ongoing training. And we've got to realize that if we silo off our security teams and our public safety teams from what we do as part of our clinical mission, how can they really synergize with us to support that clinical mission? They're good, but they're not that good, right? So we've got to make sure that we're really bringing them to the table with us, right? All right. And will psychiatry fix it? Any other psychiatrists in the room? I know there's some psychiatrists floating around. All right, my peeps. All right? And by the way, again, we're awesome. We know, right? But there's some things even we can't fix. Because if we snapped our fingers and all the psychiatric illness that's out there sort of fizzles away this weekend, right? Some of us are going to get back and we're going to have a real empty clinic schedule on Monday, right? But there's still going to be like 90 to 95% of the violence that's out there, right? There's a lot of violence that isn't explained by a DSM diagnosis. Most violence isn't due to mental illness or people with mental illness, right? Most people with mental illness are not violent. Not today, not tomorrow, not to themselves, not to anyone else. But fear and bias and discrimination perpetuates those lies, right? People living with psychiatric illnesses are far more likely to be a victim than to be a perpetrator. Living with a severe psychiatric illness means someone is 5 times as likely to be a victim of a homicide, 25 times as likely to be a victim of a sex crime. The ratios are staggering, and the interventions, sadly, limited. But there is a small subset who've got a lot of psychiatric stuff and a lot of violence risk, and they blend together, right? And by the way, there's also people who've got a lot of psychiatric stuff and a lot of violent stuff. It's not connected. There's nothing about living with bipolar or schizophrenia or PTSD that keeps you from being a jag-off. A little Pittsburghism for you, right? But sometimes it's connected. And when that happens, like we as the behavioral health folks, we got to be on the spot. We got to attend to that, right? But we can also be really good at mitigating risk even when there isn't a connection. Because one of the things I've learned over the years is that most of what drives violence isn't about the diagnosis, but it's about the rest of the stuff, that biopsychospiritual formulation that helps us understand how that person fits into their life, into their community. And that's where we have the risk factors, but that's also where we have the protective factors, right? And also, at the end of the day, I'm a psychiatrist. A lot of my work is about the diagnosis, but I'm not bad when it comes to the behavior stuff too, right? And ultimately, violence is about behavior. All right, some real basic things. Like, I love de-escalation, but I love not being escalated at all in the first place, even better, right? So some real nice, preventive stuff, like good, equitable care, right? Dignity and respect. Sounds kind of hokey and cliche when you hear it, but oh my gosh, if you can do it right and do it consistently. You don't have to do it 100%, but if you can do it a lot, it makes a huge difference. Setting realistic expectations, inviting questions. So people aren't like walking out at the end of an appointment and the patient's like, hey, wait, I have more questions, right? But giving them a way to know that, hey, let's fit into your stuff. Because a lot of times that they didn't listen to me, they didn't answer my question is a nidus for a lot of problems, right? Regulations will fix it. Well, I have ambivalence. I was staring at this slide earlier up in my room and I sort of figured out, my agency's under like a dozen different regulatory authorities. That's a lot of site visits, right? That's a lot of inspections, that's a lot of record reviews. And I don't love the idea of like more criteria, but also I love any tool, any stricture, any sort of, a program that sort of says, we can do this better, you have to do this better, these are the minimum standards, right? A rising tide raises all boats, maybe, so yeah, maybe there's something to it, right? Okay. All right. Well, you are the Society for Bioethics and Humanities, so I thought you needed a poem. And I want to read this poem to you, and then I'll tell you where I found it. All right. This may be a normal day at work for you, but it is a big day in my life. The look on your face and the tone of your voice can change my entire view of the world. Remember, I'm not usually this needy or scared. I am here because I trust you. Help me to stay confident. I may look like I'm out of it, but I can hear your conversations. I'm not used to being naked around strangers. Keep that in mind. I'm impatient because I want to get the heck out of here. Nothing personal. I don't speak your language well. You're going to do what to my what? I may only be here for 4 days, but I will remember you for the rest of my life. Your patients need your patience. I love this. I'll be back at work on Monday. For me, it's another Monday. For the people walking through my building, our crisis center, it may be the worst day of their lives, or they may be there with a loved one. It's the worst day of their life, right? And it's hard to remember. It's not just another Monday for them. Anyone want to know where I found this? Yeah. And by the way, I want to be clear, I have no idea who wrote this. And if any of you know or find out, I would love to meet them and thank them, because I love that. I found this more than a decade ago in a staff lounge of the public safety team at one of our local hospitals. I'd gone over there to pick up some footage of it for a security thing, and as I'm hanging out in the staff lounge, as they're pulling it off the server for me, this is on the bulletin board framed, right? So like not out front like virtue flagging, this was there. Someone said, we like this and we're putting it up for our staff, for us. And I love that. And I think in that team, it shows through to this day that that's sort of the values of this team, right? All right. Well, sometimes it's us, right? I love this mnemonic. It's just sort of, before we step onto the stage, in the morning, as we swipe in, as we get out of the car in the parking lot, or, step off the bus to head into work. Like, what are the things about us that might take us down a notch, that might impede our situational awareness or our compassion, right? Illness. Remember when we used to be like, it's only a little bit of a fever and the respiratory symptoms aren't that bad. I'll just Purell a lot, right? Now we're swabbing until we're having, these transsensory experiences, right? Medications. A new medication, we missed a dose, something's just a bit off. Stress. No stress in healthcare, none at all. Zilch, zero, right? Alcohol or drug use, right? And this might be the capital SUD, substance use disorders, for which none of us are immune. Or it might just be, the Steelers game went a little bit late last night, and I had a round of whiskey a little bit later than I usually do, and now I'm coming in, and I'm not quite on my A game, right? Fatigue. right? Anyone know, like, what's the healthy amount of sleep we're supposed to get every night? Anyone know? 8 hours. How many people got 8 hours of sleep last night? One guy, right? That guy, right? That guy, right? But yes, right? So first of all, yes, let's celebrate someone actually taking care of themselves and not painting the town, right? As one does at conferences, right? But like no one else here said, 8 hours, really? I never heard that before. I thought it was 4.5, right? No, we know better. And yet life happens. Kids happen, calls happen, it's a strange hotel, or it's good networking, right? All this other stuff happens. And again, we come in and we're a little bit tired and we're not quite on our A game. Oh yeah, eating and elimination, right? If we haven't eaten enough, if we aren't well hydrated, then we'll be a little bit off and we can be a little bit more irritable and cranky, right? The research on the hangries, it's not just for a Snickers ad, right? It's a real thing. If you ever look for it, there's some really fun research. And maybe it holds up over time, maybe it doesn't, but it looks at decision-making by probation judges, and they get a lot crankier when they haven't had a meal break recently, so, all right. And sometimes one of the things we do as healthcare professionals is we put our stuff on our patients, right? So the psychodynamic term for it is projective identification, and it's, I'm not angry, you're the one who's angry, right? And it might be because I can't deal with sort of my own anger or hostility, or it might be something else that sort of got me primed to look for dangerous things in the environment around me and to misinterpret those, right? So I'll just let you absorb this tweet. Yeah, is there something? Oh, I'm getting looks for that one. Oh boy, right? Yeah, right. There's sometimes there's this lens that we look through that we miss something, right? And one of the first things I was sure to do is I step into a situation where people are upset is like, what is going on around here? And by the way, is there something about like my lens and my frame that I'm going to miss something important because of who I am? Because I'm just as like, cis and white and upper class as I look, right? I always joke I grew up at the intersection of wonder and bread, and that's not too far off. But it sets me up for a lot of really serious mistakes, and so I've got to be super vigilant, in the settings I work in here, right? Because fear makes us stupid, right? And when we're stressed out and when we're nervous, we become hypervigilant. Hypervigilance is a symptom. It's not a skill, it's not a strength, it's certainly not a leadership trait, right? But what happens is when we're stressed out, we look for threatening things around us, right? When we're in survival mode, we're worried, like, what's that dangerous thing that might come up after us, right? You will never hear the testimony of someone saying, I got out of the car, I was running down the street, it was dark, I was having a hard time seeing, the sweat was dripping off me, I turned into the alley, I could have sworn he was holding a bunny rabbit. That's not the way our brains work. When we are in fight or flight mode, when we are in survival mode, we look for the things that are dangerous, right? And we misperceive, and our brain has evolved to look at benign stuff that might be dangerous and to say that's definitely dangerous, so we can keep fighting or fleeing rather than get hurt. And that can set us up for some terribly dangerous mistakes in healthcare, right? And we get reactive, right? I was at a meeting a few weeks ago with some really smart people who do this broader thing called threat management, which is how we deal with targeted violence. And one of the things that one of the lawyers who was there said that I just absolutely loved. She said, listen, when we frame this around threats, when we frame these things around, the final bad thing that happens, we lose an opportunity, right? We want to say this is about conflict. This is about disruptive behavior because we want to step in. We want people to be reaching for help when something is just starting to happen that's a little bit disruptive, right? I can't tell you how many conversations my threat management team has had with a practice because they had a little bit of a conflict with the patient and they kicked him out of the practice and then everything kind of went to hell and they're like, oh, how did it get so bad? I'm like, because you had an opportunity to repair and you kicked. And somehow or another, when someone gets kicked, they don't like it, right? Imagine that. I wish there was some magic phrase, right? Some magic, terminology that we can use that would, resolve every situation. I wish there's some cool like Vulcan nerve pinch, right? There isn't, right? A lot of it's the same basic stuff that we get from all the RCAs we do, all the other errors and problems we see in healthcare. Good teamwork and good communication. And by the way, in inpatient, communication is, hey, let's huddle up really quickly before we go see the next patient or before we do the next procedure, right? It's the pause before they start that surgical procedure. And outpatient, it might be a daisy chain of epic messages and emails, right? It can be a little bit trickier to do that same kind of teaming, but we got to find ways to do it. I'm going to come to verbal de-escalation just for a little bit. I love verbal de-escalation. I teach verbal de-escalation all the time. We teach it in healthcare. We teach it. I teach it to law enforcement. A lot of the stuff that we talk about managing agitation and aggression, those same interpersonal skills, it's the same thing we're doing with our risk management folks about how do we deal with the conflict, with possible bad outcomes, right? And 12, 13 years ago, when my colleagues at the American Association for Emergency Psychiatry kicked off Project Beta for best practices in evaluation and treatment of agitation, we very intentionally centered verbal de-escalation because it's the linchpin, it's the keystone for everything else, right? Whether we're thinking about medications, differential diagnosis, it's about that verbal interaction or that signed interaction with that person that we're trying to work with and communicate with and connect to and to help, right? It's safe. Right? One person can verbally de-escalate someone else, and I can tell you I've seen people de-escalated who were like this, and I really didn't want to go hands-on because they were going to mop the floor with me, right? It's effective, it's efficient. If we're going to put someone on the ground because they're aggressive, the way we teach it in our system, we need someone for the legs, someone for each arm, someone for the head, someone to do sort of that whole monitoring, making sure they're okay. And then we need someone to say, oh, get help, because Rozel popped off again and we need more support, right? Whereas if we have one person in the tunnel with that other person verbally de-escalating, that can be all it takes. Now, by the way, it's not a lot of fun to be just that one person with a really scary person. It's nice to have some people with you, but you can do it, right? I'd love to sit here and say that we have really fantastic multi-site randomized blinded clinical trials that show that verbal de-escalation are fantastic. It's not easy to do that research, right? I wish we had better data for it. We've reached the point where we now have the systematic reviews, and they say the same crap all the systematic reviews say, which is, gosh, different definitions between different studies make it hard to compare. It's probably helpful, more research is needed, right? I've seen that in like every systematic review ever, right? But also it seems to be really helpful. And also we need to do better to understand what parts of it are helpful, what parts of it can be more helpful, and what parts of it we can get rid of, right? Because we don't have infinite time for doing that. And I always like to point out, we have no randomized blinded placebo-controlled trials for parachutes. And if something goes wrong with the plane, I do not want to be randomized, right? So things to think about, right? But verbal de-escalation can be easy. And I'm going to show you this really short clip. You may have seen this. It kind of went viral on social media, at least on my social media about 2 years ago, and I love it. And so we're going to play this video. The video is a little bit quiet, so all right.
Okay. See, that's a confidence.
I know. This kid's amazing, right? Oh, I love this, right? So he makes eye contact, right? He makes sure he gets in the other person's sort of line of sight and engages. And it's not, you need to breathe because you're upset. It's, no, we need to do this together. It's gentle redirection when the little kid doesn't get it, and it's positive reinforcement as soon as that other kid starts to get it right. It's not always that easy, believe me, but also it can definitely be that easy, right? So easy, that kid can do it. Now, by the way, that kid, awesome. I don't know where he gets it, but he's got it, right? All right. Seriously, or are you messing with me? Are you serious, or are you messing with me? No, okay. Yeah, okay, all right, yeah, all right. Couple other things to think about de-escalation, right? Design matters, right? Spaces matter. as you think about how are you going to design that next outpatient clinic or that next wing of the hospital, patient flow and making sure we're able to do the procedures in the right way and people aren't too cramped and we can get the code carts, through the doors and everything else are really important. But also designing for safety really matters as well, and it's got to be a priority too. And it's also got to be comfortable and welcoming, right? A few years ago, my wife and I, we went to update our will and estate papers, and our attorney, great guy, he's a military veteran, and on his wall was this like Rosetta of combat knives from around the world, right? I'm a child psychiatrist, and I came in and I was like, oh, I'm having a moment walking in, right? You don't see a lot of that in child psychiatry outpatient offices. Your mileage may vary, but I haven't seen that, right? Training helps, right? But some people you can train till the cows come home, and they may not be your choice person to lead the next verbal de-escalation. It's nice not to be alone, but sometimes you are alone, right? It's hard to fake confidence, and it's a bad time to fake anything. And I haven't quite figured out the dynamic, but I've seen it time and time again, and it may just be my own damn insecurity, right? But I feel like when I'm trying to de-escalate, I'm like, they can tell when I'm bullshitting them, right? And maybe it's because they're more vigilant, and maybe it's because I'm more vigilant that I'm going to screw something up. But sincerity is generally going to be a much better intervention than insincerity. And I don't know about the formal ethics rules on that, but I can tell you at a practical level that's worked out for me fairly well. All right. Engaging someone who doesn't really want to talk to you, right? So some of this is, it's not, I am Dr. Rozel and I'm here to help you. It's like, hey, my name is Jack Rozel, I'm one of the docs, can we chat for a little bit, right? And I'll make a point of sort of flagging my tag so that they have like a name and a reference and, I'm not just some, rando walking up, right? But it's not, I'm asking, can we chat? Can we talk for a little bit about what's going on? We get on their level, right? In law enforcement training, they talk a lot about like you use your physical presence to get submission. I'm not trying to get submission, I'm trying to get engagement, right? I want to be on their level. I'm a child psychiatrist. I spend a lot of time with our butt on the floor because that's where kids live, right? And so get used to that, get comfortable for that, right? It's nice if we can build that rapport on some non-controversial stuff before things have gone to hell. It's nice maybe for the verbal de-escalation to be led by that clinician or that staff member who's been working with that person all along about all the other stuff about the IV and let's get the bed turned over and blah, 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 before we've got to have that intervention around they're really upset about fill in the blank. We can empathize on emotions. But we don't want to endorse problematic behaviors and beliefs. Those neurology people, blah, 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 right? Again, psychiatrists, we love blaming neurology for stuff, but that's not the time or the place, right? And get on their side. And Janet Richmond, who wrote a wonderful article on verbal de-escalation, we'll share the link of that for you. She always says, getting on the patient side, if not literally, then at least metaphorically, right? So it's nice to sort of be with them side by side as they're pacing up and down the hallway. That's great if you can do it. But it's not, I'm de-escalating you because you're upset. It's, you're pissed off because you're NPO and your mouth is parched and you're hungry. I'd be pissed off too. Let me see if I can get some clarity on that and figure out like what the timeline or what the boundaries are. Can we at least get the ice chips? Ugh, I hate the ice chips. But like sometimes it's better than nothing, right? It's not, again, it's not I'm de-escalating. It's you're pissed off about something. I want to help you with that thing you're pissed off about, right? Finding a way to join with that person, right? If there's a good slide, like to get all of this, I would. It's hard to learn from a slide deck. It's hard to learn from someone who's been doing this 6 months longer than you have. But we got to figure out how to make it more learnable and how to make it more shared, right? And we've got to realize that just because we do really great training, when you're in the midst of a really heated situation, it can all go to hell real fast, right? When someone's got you cornered against the wall, spit and saliva coming out, maybe they've even got you physically held against there. And they're talking about how they'll kill you. They're talking about they're going to find and rape your children. It's really hard to get back to that compassionate space, right? It's really hard. And that's something a lot of our staff face all the time. Put more scientifically, we make errors more when we are under stress. And working with someone who's angry or agitated or threatening us is really stressful, right? There's some stuff that helps, right? being aware, right? If you're in one of those awful situations thinking, this is not the time to remember like the slide, but right, also remember it's a bad situation. Of course I'm stressed out. Of course I've got that flop sweat going on. This is kind of what we expect to happen in our bodies when we're in high-risk situations. Man, I hope you don't have to build up a file folder on that experience. But if it's happened to you once, you'll be a little bit more comfortable with it happening to you again, right? Breathing, like that little kid did in the video. That circuit breathing, that mindful breath, right, can make a world of difference. And often I use that as I step into the room, step into the situation. That's my grounding breath and a prompt for me to do that survey. What's going on? Who are the people at conflict? What else is happening behind them that no one else is attending to, right? We talk about the primary survey and then the secondary survey and the trauma bay. Kind of the same thing when we're dealing with an agitated person, right? We have the two people who appear in conflict, but what's going on around them? And I can tell you if it's in a waiting room or in an inpatient behavioral health unit, someone else is getting up to some shenanigans out there, right? And we got to make sure we've got eyes on them as well, right? And consultation, never worry alone, right? That can be a really important tool. And again, it's a little bit trickier because an outpatient, that never worry alone might be, you might have to force that team meeting for everyone because it's hard to do that through epic messages and emails, right? All right. Sometimes we start with our clinical differential diagnosis and we say, is this agitation because of pain? Is it because of, an emerging delirium? Is it because of they're not happy with the quality of care? Is there something else we can do? We sort of work our way through that differential. And sometimes left at the bottom is they're doing criminal stuff for criminal purposes, right? That shouldn't be the top of our differential. That should be a diagnosis of exclusion. But sometimes that's where we end up, right? And sometimes our treatment teams are like, they're a criminal. We want charges. And by the way, I'm not aware of anything that says by virtue of being a healthcare professional, you have lost the right to seek an investigation and potential charges against someone who you think has done criminal stuff against you, right? And also, I think there's an intrinsic difference between that patient who's sundowning and the patient care aide is helping them with their ADLs and they grab and they scratch, versus the person who's cornering someone in the parking lot saying, you will give me that Adderall or I will find you at home again, right? Different situations require different tools, right? But remember that just because you've said this is criminal stuff doesn't necessarily mean that it's the end of the interactions between you and that person or your system and that person. And we've got to be thoughtful about how we manage those points and think of them more as a fork in the road or a turn in the road rather than the end of the road. Because especially, again, I work for a large system, right? We're the largest healthcare provider and the largest insurer in our state. And so if we fire them, they're going to go right next door to the very next practice within our system. And it's, lather, rinse, repeat. So we've got to be thoughtful about how we manage this and hopefully, again, get upstream before that stuff happens, right? And also, especially in the ER and the psychiatric ER all the time, it's they did something illegal. We expect them to go to jail and get locked up forever, right? Or, out in the community, my law enforcement partner said, they did something really weird. It's a psychiatric emergency. We expect them to be hospitalized forever, right? I get it, and I get the tension, and I'm in those dialogues all the time. When sometimes people do get picked up and arrested and they're out the door, sometimes within minutes or hours because they don't have any outstanding warrants. It's not a substantial enough charge. And my clinical staff they're raging. They're like, why wasn't this person kept in jail? They clocked a nurse, right? And I'm like, yeah, legit, that's a bad thing. And also, it's actually a good thing because for them to have done something bad enough that the magistrate's going to keep them locked up for an extended period of time, awaiting trial, blah, 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 they would have had to have done something really bad, and it would have been a lot worse than a split lip, right? So we've got to think about how we're working all across that pathway, right? All right, so again, I'm a child psychiatrist, so we've got to do some child psychiatry stuff for you. The way we learn to attach to other people in our lives, at least according to some theories, has a lot to do with what happens when we're kids, right? Can we safely venture away from our parents and trust that they'll be back for us when we get there? Do they support us or do they overly protect us? Or are they inconsistent? And depending on that experience, it changes what happens, as we go through life and as we try to form attachments with others, right? Those earliest experiences with threat and novelty can shape how we respond to the threats and risks in the future. And sometimes intentionally, sometimes unintentionally, we reenact, we recapitulate this through our life with our coworkers, with our bosses, right? And so as leadership, we need to be mindful of that, right? And we know that we get better clinical outcomes, we get better morale, we get lower turnover, less burnout if we can foster some of those secure and healthy relationships, right? It's about hope and trust and transparency. And it's, as I put this slide together, it occurred to me, because I'd used a slide very much like this years ago in the past, and as I was putting it together for this, it occurred to me over the past several months, some of the very best outcomes I've had in consulting on workplace violence, and some of the worst outcomes, which were bad not because anyone got seriously hurt. In fact, it was a situation where someone had made a threat and immediately recanted it, but the eruption of the staff about what's going on, it came back to the attachment stuff. It came back to their trust and the effectiveness of the leadership to be supportive and genuinely and sincerely supportive and consistently supportive to their team, right? So yeah, right, some of this stuff really matters. Jean Dysinger, who's a wonderful psychologist who does security work, says, fear and danger are different things, right? And as leaders, we are responsible to address both. But how we prioritize them and what we do to fix them, right, is going to be different depending on the circumstance, right? But if you think that fear wasn't disruptive for that kid, right, it was tremendously disruptive, right? So we enter medicine to heal, to aid, to comfort, perchance to make the world a better place, right? The world does not always meet us with equal compassion, though we wish it did. And when our systems are exhausted and our teams are depleted, the work is harder and the nerves are more fraught. There's much we cannot control, but we should seek control of what we can. And each of us every day, both as clinicians and as leaders, have to think about how we attend to our safety and the safety of our colleagues, right? And we have a little bit of time to cover this, all right. I don't know about the rest of you. I'd say the past 4 or 5 years, they've been rough. And I kind of have this feeling a lot of mornings like, do I check the social media scroll? Do I check the news? And one of the things, and I know those of you who overlap a lot with risk management stuff will appreciate this, like sometimes you really don't want to read the headlines because you sit down like, please don't let this one be mine, please don't let this one be mine, right? And knowing that medicine in 2024 is really different than when I started med school 30 years ago, or at least maybe I'm more aware than I was 30 years ago, but I think it's different as well, right? But this messes with us, right? So part of what we can do is we can be thoughtful about how we prepare for stress, for ourselves and for our teams. I started med school in the mid-90s. It was sort of the peak era of like ER and Chicago Hope, and I like Chicago Hope better. But maybe it was just because like the hospital director was smoking cigars in his office, and I'm pretty sure I will get in a world of trouble if I pull that. Right, we got to think about how we get our staff ready for this. And part of this is also like, what is the value offer we're making, not just to our staff, but to our trainees and the people entering our field. When I was thinking about going into medicine, I did it because I'd been lucky enough to be able to volunteer in an ER near where I grew up and had an incredible experience. And the doctors and nurses there were just, I'm still in awe of them to this day, right? And I saw the flash and the excitement and what they'd be able to do to help people. And that was so, so deeply appealing to me. And it still is, right? And when I went through med school, I was learning about, electrolytes and, hormones and kidneys and heart functions and all this other stuff. And then I got to the floors and I was learning how to do IVs and, intubate and how to talk to patients and get histories. And I don't remember getting a lot of training about how to work with aggression. I don't remember being told that I was entering one of the most dangerous professions for workplace violence. And I worry about the morality of what we're telling our trainees today. As we invite them to join us in this space, which is wonderful, which is incredible, where we do truly life-altering, deep and meaningful work, but also work that sometimes has a cost, and sometimes a terrible cost. And we've got to think about what we do, right? And some of this is as we build in our systems, as we recruit, as we train, and as we schedule people to sort of build in the space to deal with stress, right? So I was on the phone with a friend of mine. She'd just taken a punch from a patient. And she felt about it about exactly as you might think she might feel about it, right? And we talk about all the time about like resiliency and what can we do like to help our staff be more resilient. Pro tip, not a pizza, right? Also, I love pizza. I'm not going to say no to a pizza, but let's not overestimate the healing, the moral healing power of a pizza. It's finite, right? It's tasty, but it's not going to fix the problems inherent in the system, right? And I love the idea of resiliency, but we also have to encompass and address the fact that we shouldn't have staff feel like they need to be resilient to the stuff that we do to them, that the stuff that we do to each other, that the stuff that our system is designed to do. I was talking with a team that had just a devastating loss in the context of ongoing and just awful things. This was peak COVID, and this was a clinical team that had been through some of the most terrible things I could imagine any clinical team having to deal with, coding coworkers, right? And one of the folks on this conversation sort of says, and I don't think it would have been anywhere near as bad, but we were also transitioning our EHR at the same time, right? And I just sort of said, right? And a lot of times it's, there's some stuff that really can help us deal with things when we're stressed out, right? Like yoga. I love yoga. I do a couple minutes of mindfulness every morning, right? It's become a really important part of sort of how I'm able to go through my days, right? And it's like the best time to do that stuff and to start doing that stuff is 3 months ago. The second best time is to do it today, right? I do a lot of trauma work, but we have different interventions for different times, right? I've worked with a lot of firefighters over the years who've done some incredibly dangerous, heroic stuff and seen some things that left a mark, right? You will never see me in the bunker gear and the helmet walking around a structural fire, tapping them on the shoulder, saying, how are you feeling right now, right? That's not the right time for it, right? They've got to do their job. And then, afterwards, we can do some other stuff, maybe some CISM, and maybe if they need it, we get them to a good trauma therapist who can do the right kind of work with them. But there's a right time and a place for all of these interventions. And we've got to be thoughtful about that, right? All right. I love this line. When I opened up the command center at our hospital after a mass casualty event that happened in our lobby in 2012, it was an active shooter, killed one of my coworkers, injured 7 others, one of whom died of consequences, not an official medical legal opinion, my personal opinion, right? This was the first thing we wrote on the wall, on the whiteboard at the command center, right? Again, the work is wonderful, but the work has a cost. And especially at a leadership level, and especially in healthcare, we're driven to serve others to a sometimes dangerous degree. And I see this in my colleagues all the time, right? My gosh, if I call off, what does it do to the schedule? Who's going to cover consults? Who's going to cover the clinic, right? How disruptive is it going to be to the schedule? And we push ourselves to perform for our team, for ourselves. And again, we've pushed ourselves our whole life to be the professionals we are. And there's a risk and there's a balance. And maybe there's also a reason why burnout and trauma-related illnesses and suicide are so significant in healthcare professionals, right? We've got to remember to put our own oxygen on first and to remember to do a little bit of self-care and to have a little bit of grace and humility for ourselves and our teams as we go through this process, right? How many of you heard the saying, it's a marathon, not a sprint, right? We say that all the time. We had the big critical incident and we're trying to support the team. It's a marathon, not a sprint, right? We've got to keep on, right? First of all, how ableist is that, right? I mean, it's just like there's so many, right? But not everyone is at the starting line in the same condition, right? Marathon fit, carb loaded, and the magic sneakers and shorts and jerseys and everything else that will get us through the next 26 miles, right? Some of us are beat down, worn out, and ragged from everything that we just got through just to get to what you're calling the starting line, right? And so as our teams go through critical incidents, as our teams deal with serious workplace violence, we've got to remember some of the humanity that's part of that process. And by the way, for those of you who are history buffs, do you know what happened to the first person who ran a marathon? He died, right? Again, not a cardiologist, but it seems like a bad outcome to me. I'm just floating it out there, right? All right. While we're on the classics, I'll give you sort of a last thought here, right? Are you familiar with the ship of Theseus? It's this philosophical problem. If over the journey we replace every part of the boat at some point, is it still the same ship or not? When we have critical incidents in healthcare, I see turnover accelerate. I see people thinking, this isn't maybe the right career or the right place in my career for me to be, right? And people move and people change. And that's okay, right? Turnover happens and it's all right. And there's always been a half-life to every position and every person. But the cumulative trauma happens and it accelerates this. And it sucks, right? After major incidents, we won't be the same. And that's okay, right? And our organization will change. And that's okay. Because if your organization isn't continually changing and responding to the events that you have experienced and the things you have learned from, then you're in bigger trouble than I know how to help you with, right? But we got to stay true to purpose and stay close to our original mission, right? And that means that if the oar breaks, we do not replace it with a pretzel rod. We replace it with something else that's going to help propel our ship and stay on course, right? Early in COVID, when those Zoom happy hours were all the rage, I was on a call with a dear friend of mine, Apajek Jain, who's a forensic psychiatrist out in New York now. And he said, healthcare's changing and it's evolving. And then he said, but evolution happens in a couple different ways. And sometimes it's slow, right? The currents change and the mangrove swamp dries up and the salamander has to evolve and the plants and the species all change slowly and gradually over time. And sometimes the meteoroid hits the side of the planet and things change catastrophically and suddenly. And I think in healthcare, we are at that point in change. In part because of lots of things, because of COVID, because of the dollars, because of workforce issues, and in no small part because of what's happened, the surge of the occurrence of workplace violence, but also the surge of awareness of the workplace violence that was there well before the past 5 years, that we're now trying to do a much better job of handling, right? And we need to take some responsibility and realize that, yeah, evolution happens, but we have a responsibility to help shape our workplace for our patients, for their families, for our coworkers, right? With that, I hope you have what you need to go back and have some great days for yourself and for your team. Thank you. I think we have time for questions. Yes? Did I time it right? Okay, excellent. All right. Yeah.
Yes,
sir.
I'm Jonathan Bolton, a proud graduate of Western Psych.
Oh.
And I was wondering, you referred to the catastrophe in 2012, and obviously I'm interested at the level of organizational ethics, how WIPIC responded and what you think you got right, and what were the costs of the changes that you implemented in order to have more security, more safety?
Yeah, right. On the morning of March 8th, 2012, as far as I know, there'd never been an active shooter incident where someone had come into a hospital and opened fire going for a body count. That changed at about 1 o'clock that afternoon. One of my coworkers died, and the workplace that I had trained in, that had been my home in so many different ways, was transformed forever. In the months leading up to that, Carla Gedman, who was our public safety director, had been going around team to team, unit to unit, program to program, and had been teaching run, hide, fight, right? And preparing for active shooter readiness. We talked about having a special alert code that would be different than a code, because what do you do when there's a code? You run to help, right? And in fact, one of the things that happened that day that happened was, as some of the codes were misunderstood by our neighboring hospital, the trauma team ran to help. And at a time when it wasn't clear that the shooting actually had been resolved by then, but it wasn't clear. And there was obviously a lot of concerns about that. But also, it's a hospital. And it was the first time something quite like that had happened. And so, you know what? It wasn't a hardened entrance. There wasn't an arch metal detector. And I've now been working in this space for a while and can tell you that when there's a hard perimeter And a lot of folks who've served in the military overseas, the Iraq and Afghanistan conflicts will tell you that when you create a hard perimeter, you move the point of conflict to that perimeter. You don't stop the conflict, you just relocate it, right? And to be able to put a hard perimeter into a healthcare setting is incredibly difficult. Because to this day, there have been very few attacks like that. There are shootings in hospitals, quite a bit. There are suicides, there are staff conflicts, there are murder-suicides of bedded patients. There are suicides in our parking lots. There are folks there from jails and prisons who get a hold of their security officers' guns. But this type of a thing does happen, but it's very rare, and I hope none of you ever have to go through it. We've learned a lot from it. We've definitely hardened our perimeter. It's not cheap, but you don't get a second one, right? We've changed a lot of our approaches to how we handle that security, and we spend a lot of money and time and resources on security. And we fight very hard to find ways to protect that and to embed those safety professionals within the rest of our mission. To be clear, this incident wrapped up in under 4 minutes. University of Pittsburgh police were very close by. They entered and they put the shooter down at 3 minutes and 40 some odd seconds from the beginning. But also, the initial concern was there was a second shooter, and so we were locked down and evacuating our patients for hours through this. But we've learned a lot, and we've tried to share what we can with others, and yeah. I don't know if that really answered your question, and hopefully I didn't just trauma it up, so yeah. Oh, yes, sir.
Yeah, Dr. Rozel, thank you so much for a great talk. I'm Kayhan Parsi. I'm the immediate past president of ASBH. Actually, when I was looking at your card, I didn't even realize I was a dinosaur until right now, so awesome images. So I was just reminded of another movement that happened 20 some odd years ago called the patient safety movement, right?
Yep.
To err is human. And that report relied heavily on other industries, such as the aviation industry, in informing healthcare and how to improve patient safety practices. Now with the healthcare safety movement, healthcare worker safety movement, I'm curious, are you learning anything from aviation? Because of course, in aviation, no one ever gets angry, right? No one's ever stressed out. And so I'm curious, are you learning from best practices from aviation to inform healthcare?
Actually, aviation is learning from us. Oh. I've talked with a few folks in the aviation field, and that article I mentioned before by Janet Richmond and her colleagues, they're actually looking at that and how they train their flight staff. The pilots and the cockpit crew have very specialized technical training about all that type of stuff. The folks inside our cabin, what they spend most of their time learning how to do, like 95% of their training, is how to get us the hell off that plane as fast as they can if something really bad happens and they got a ditch, right? That's like 90 to 95% of that training. And now they're starting to think about how do we teach them a little bit more about conflict and how to manage that and how to deal with someone who's upset, because they haven't really had that, right? 95% of my interactions with flight folks are like Diet Coke and pretzels, right? But now they've got to learn how to do a little bit more, so they're starting to look at that. But also in healthcare, how do you manage those rapid perimeters, right? My family and I, we got to go see Hamilton the other night as it came through Pittsburgh. Great show, by the way. But, they have these specialized metal detectors that let us go through very quickly, right? And they're sort of, complex and enhanced, but also security isn't just technology, it's also people and process and culture. And so, but also the technology can make some of the other stuff a lot easier, right? And also, we learn from our colleagues in security and law enforcement. I do a lot of work in this space, and I work alongside a lot of folks from uniformed law enforcement, from investigations, and from the intelligence community as well about how we think about this type of stuff. And I think it's intensely beneficial in how we approach keeping the workplaces safer, to keep the workplaces safer, and to protect the fundamental clinical mission. So.
Thank you so much. It was a wonderful talk, and this is very important to me. My name is Michelle Bach. I'm a bioethicist by training, but also currently a psychiatry resident. Yeah, still going. And I was assaulted as an intern, as have multiple of my co-residents. Yep. Where I'm training, a patient was killed, I would say murdered, by the VA police at the local VA. And so in response, our program hired a self-defense coach to come and talk with us and teach us how to defend ourselves. And the man teaching this was not a philosopher by any means. He was a former soldier, but his argument was that there is a point where, you know, deadly force is being used against you as a healthcare worker, where that patient goes from patient to criminal, and it becomes permissive to inflict harm purposefully on that patient, what was a patient. And I left, but I don't blame the people who stayed. And I would like to hear your comments about programs that are bringing in these kind of trainings.
I have concerns.
Yeah.
And I think we're in a room of bioethicists who also mostly have concerns, although I don't want to speak for everyone, right? Listen, at a sheer mechanics, you know, at a sheer physical dynamics level, the techniques and intervention I have to use to defend myself against one person when it's just me is entirely different than what might happen in a healthcare setting where I have 4 or 5 or more colleagues, right? For me to safely put someone on the ground in a way that they can be safe on the ground and that the transition is safe as well and that we are safe in the process, relatively safe people are still at risk. It takes more people and more skill and more training than a knockdown, drag-out brawl or using the techniques that someone needs to use one-to-one. And what we teach, you know, for example, the state police in the state of Pennsylvania, who might not have another sworn law enforcement within a 20-minute radius of them at any given point in time, is going to be very different than what we teach to our clinical staff. I think healthcare settings need to make sure that we are staffing and resourcing in a way that we have the right kind of resources, that no staff member is ever in a one-to-one situation like that, right? And it's tricky because we can't predict everything. But we need to make sure, again, that we have the right resources and tools and awareness in place and make sure people have the right education and training. I can't create a system that's going to defend against everything, but I can line up a lot of layers of Swiss cheese and keep adding more layers of Swiss cheese as we go on. But there's always going to be risk. So.
I know that there are 2 questions here, and if you could ask them simultaneously, and then allow Dr. Rozel maybe to respond to both, and then we can transition to have further conversation in Region CC
Yep.
445.
Yep. Okay.
It's okay. I'll see.
All right.
My name is Lisa. I'm from Minnesota, but my background, my first career was in law enforcement. Okay. I'm 5'3". So in California, where I was trained in law enforcement, I got my degree in Minnesota, went to California and trained in law enforcement. And there they train you to have verbal judo. Because again, 5'3", I'm not going to be as effective against a 6-foot man, right? I mean, so before we were able to roll to the streets, you had to put in your time at the jail. So you have no lethal weapons on you, but you have your voice. And so now I work in adult mental health as a clinical social worker. Mm-hmm. What I see is the lack of training in verbal judo and the de-escalation skills.
Yeah.
And the fear of some of the people I work with. And it doesn't feel good going into a situation where I can see these young people working as patient techs when they don't feel comfortable with the patients around them. That's not a good place to be. So my hope is that it's a young unit, and my hope is that we get the training for the people that don't have those de-escalation skills. So I appreciate that you noted that, and thank you.
Yeah, and by the way, Verbal Judo, great book, great audio book. I don't know if the team is around that still does the trainings. The original author is retired or possibly passed away, I'm not sure. Wonderful book, I love it. But yeah, and I'll also say one of my early mentors was one of our trainers in our program at our hospital when I was a resident, and she had actually gone law enforcement, hospital security, and trainer, and is actually now a social worker as well. And she was probably a little bit shorter than you. And also, by the way, could also mop the floor with my ass, but was deftly skilled at working with someone in crisis and being present. One of my first dip in this, the crisis line Dr. Smith mentioned, we didn't trace calls. So if someone didn't want to be helped and I couldn't talk them into wanting to be helped, the line would go silent, right? And you learn some things, and you learn some things about yourself about that, right? So, did I lose someone with a question? I think I did. I'm so sorry. Okay, I'm so sorry. Thank you. Thank you to interpreters as well.
Yeah, well, thank you so much, Dr. Rozel, for that very important session here that touches so many ways the work that we do in the way that you did it here. We do have an opportunity to continue this conversation, share your thoughts, ideas, discussion over in Regency C at 4:45. So please feel free to take a bio break, grab some water, and join us over there, and we'll see you then. Also, for those of you who decide not to join us, this marks the end of our 2024 annual conference. Yes, give it up. Hey, come on, that's right, that's right. Now, we're not celebrating the fact that it's ending maybe, but it was a good week of just being together and reflecting again on things that are very important to us, and some wonderful presentations this week that we have all experienced, workshops, affinity group meetings, reconnecting with those who are doing similarly shared work, and all the collaboration that happens in between spaces like this. So we look forward to seeing you next year, back in October in Portland. Until then, do take good care.
Thank you.